Hello, everyone. Thanks for joining us today. I am here with Dr. Rachel Zoffness, who is a pain psychologist and an assistant clinical professor at University of California, San Francisco School of Medicine, where she teaches pain education for medical students. She also serves as pain education faculty at Dartmouth, and she completed a visiting professorship at Stanford University. Dr. Zoffness is the co-president of the American Association of Pain Psychology and serves on the board of the Society of Pediatric Pain Medicine. She's the author of the Pain Management Workbook, an integrative evidence based treatment protocol for adults living with chronic pain, and the Chronic Pain and Illness Workbook for teens, the first pain workbook for youth. She also writes the Psychology Today column, Pain Explained. Dr. Zoffness is a 2021 Mayday Fellow and consults on the development of integrative pain programs around the world. She was trained at Brown University, Columbia University, and many other distinguished academic and clinical institutions around United States. Dr. Zoffness, thank you so much for joining me today. I have so enjoyed, reading your latest book, and I hope our readers check this out, the Pain Management Workbook. And I am super excited to talk with you about your work, your book, and pain.
Thank you so much for having me. And it's so funny. I literally never get used to people reading my bio. It just like feels so funny all the time. But yeah, I'm excited to be here too. And I think it's so important to talk about pain medicine and what we're doing wrong and what we can do better.
Absolutely. And I know, you and I have talked about how it often does feel weird to, talk about our credentials. But, I can't think of a better person who is more credentialed, to talk about this and spread the word about some healthy ways to live with pain. So first of all, I would love to just hear a little bit about how you got to be a pain psychologist, how you got to write this book, and how you got to the work you do.
I'm going to make that answer as short as I possibly can because it's been a bit of a journey. First of all, there are not that many pain psychologists out there because, as of course you know, in Western medicine, you either have physical pain and you go to the doctor, your physician, or you have emotional pain and you see a psychologist. And the training programs reflect that too. So, physicians get trained in pain, sort of. They get trained in pain medicine and medications and surgeries for pain. And psychologists really never talk about pain at all. Like you can do behavioral medicine and you can learn about working with people who are living with chronic health conditions, but really you don't get any pain education at all. So my interest in pain actually started as an undergrad at Brown. I deeply loved my mentor who has since passed from cancer, but she was the dean of biology, Marjorie Thompson, absolutely amazing. And she knew that I was striving to live at the intersection of medicine and psychology and neuroscience and science writing. And she actually suggested that I do my honors thesis with a faculty member who was studying pain. So I ended up doing my honors thesis on the gate control theory of pain. And I was fascinated by it. And pain, in part, was so fascinating to me because I was scared of pain, like most humans are, right? Like nobody enjoys it's such an aversive experience. No one enjoys the experience of it. And I went away from pain for a little while and I taught science and I was a researcher at the NYU Child Study Center. And I, eventually went on to get my PhD in clinical psychology. And again, very little pain education. I worked with a lot of kids and adults with chronic health conditions, but no pain education. And then I did my postdoc training in mindfulness based stress reduction, MBSR, for chronic pain. And it really sounded so strange to me that anyone would be using mindfulness for a physical problem. Like, what does mindfulness have anything to do with I had chronic leg pain at the time. And I was like, what would mindfulness have anything to do with my leg? It's funny that I was such a skeptic having studied pain, and what was really interesting about that experience was that doing the mindfulness practices every day, which was part of my training, actually did change my pain. Um, and I linked up with a neurologist not long after that who said, I hear that you do cognitive behavioral therapy, and I'm reading all these studies in medical journals that cognitive behavioral therapy is now considered an evidence-based treatment for pain. She said, I don't understand. Can you read these papers with me? So she and I got really nerdy and we read a bunch of papers together. And I emailed the authors and I said, I understand you're doing cognitive behavioral therapy and that's my training. But what's the for pain part? Like, what's the protocol that you're using with your patients? You're saying they're improving. What are you doing? So they sent me the manual, and anyone who's been trained in cognitive behavioral therapy could use the manual. Honestly, anybody. And I just like read every paper and every book I could get my hands on the science of pain, cognitive behavioral therapy for pain. Obviously I didn't invent it. It had been around for a while. I just read everything and I just thought it was the most fascinating thing I'd ever done. And then the neurologist sent me her hardest patient. True story. It was a kid. He was 16. He had been in bed for 4 years. 4 years. He had like long unwashed hair when he came to my office. He was, heavy. He had like pasty pale skin, and he was like rocking himself back and forth on my couch from the pain. And I was so intimidated, and I almost emailed her to say, I can't do it. It's too much. We went through the manual together, him and I, and his improvement probably started, I would say, within the first 3 or 4 weeks. And his function started improving first, because that's often how it is with pain. Function improves first, pain and symptoms usually follow. And that's what we saw. His function started improving. He started going outside a little bit more, walking a little bit more, running. He ended up rejoining his soccer team. I mean, it was like, it felt miraculous to me. And his parents and I were watching his improvement, and all of us were sort of like astonished by, this is a kid who had been on all the medication. He'd been on, I think, 40 medications for pain, including Thorazine, which still shocks me, and a number of other very serious medications. And the improvement within a month with cognitive behavioral therapy was like remarkable. And we did some mindfulness, we did some biofeedback. I went to his high school graduation, and he got on stage and he said, "If you had told me 4 years ago I'd be graduating high school, I would not have believed you." And I was like, I'm an addict. Like, I'll never do anything else. I'm completely obsessed with this. Pain is so fascinating. It immobilizes people. It knocks them out. It takes them out of the game. It steals their life, their career, their school, their friends, their sex lives. And there are these doors, these routes out, but they're not popular. Unlike big pharma, I don't have billions of dollars to promote the use of cognitive behavioral therapy for pain. So solutions exist, and people don't know about them. So that's the short version, believe it or not.
That is just so incredibly fascinating and hopeful, to see a kid go from being bedridden and unable to function to graduating high school and, sounds like living a normal life, despite the fact that, he had pain. That's, well, I'm glad I'm talking to you about it, because, this is exactly the kind of thing that we need to see more of, and to know that it's possible. And
Right.
actually, one of the things that I, was thinking about as I was reading your book is this idea of living your life fully when you have pain. So many people that I see are, incapacitated by pain, and when they call, they say, I am unable to do anything at all, and I would just like to be able to do a little bit of my life, but I feel like I need to get a hold of my pain first. Um, I would love to hear kind of your view of how do you help people live their life, even if they have pain, even if they have the kind of condition where pain may never entirely go away.
Totally. So I think like the first issue to address is this idea that if you're getting treatment for pain, it means that like the pain is going to magically disappear. And I always try and sort of get ahead of that by saying, there's a good chance we're not going to be able to make all of your pain magically disappear. And part of our process together is going to be figuring out your goals in life, your functional goals. So that's exercise goals, that's work and career goals. If you're a kid, that's school and academic goals. So first of all, functional goals. And then second of all, how can you live a life even if you have some pain that's worthwhile and that you enjoy? So I think a lot of the times it's actually having that conversation up front. I have to say, part of the reason I struggle with the answer to that question is because most of my patients experience a pain decrease pretty significantly. But like you said, there are conditions where you're going to have some pain in your life. So how do you improve your coping skills? How do you improve lifestyle? How do you manage things like diet and exercise and sleep and pleasurable activities? And how do you integrate all of that into a pain program to make it really comprehensive so that, like you said, even if you have some pain in your life, it's tolerable and navigable? And I think that's a really important question. But I also don't want people to give up on this idea that your pain can change, and it's changing all the time. And we have this idea that if you have a medical condition that comes with pain, like cancer, for example, that means that your pain is fixed and unchanging. And that is never, ever, ever true, ever. And what we know from pain neuroscience is that while we easily and understandably believe that pain lives exclusively in the body, like in the part that is diseased or broken or damaged, pain is actually constructed by the brain, right? And we know this in part because of a condition called phantom limb pain, where you lose a body part, you literally lose a leg, but you continue to feel terrible pain in the missing body part. So if pain lived exclusively in the body, no limb should mean no pain. And the fact that that isn't true tells us that pain is increased and also reduced by brain related activity. So if we can change the brain, we can change our pain. So whether it's cancer or whether it's a broken leg or whatever, there are always things we can do to change our brain because we can always target our pain. So that's sort of what I love so much and why I actually funneled all of this information into a book. I felt like there were not sufficient resources for people living with pain, adults and kids, and it frustrates me to no end. And I also felt like there are insufficient pain education resources for healthcare providers too, across disciplines. I mean, physicians and biofeedback providers and PTs and OTs and psychologists like me and nurses. There's just insufficient quality pain education out there. So I just wanted to sort of put it all in one place.
That makes so much sense. Yeah, hearing you talk about this, my thought was, life is full of all sorts of challenges, and most of the time we don't go, well, I'm dealing with this thing, therefore my life is over. Um, and pain is often one of those circumstances where people might say, what, I'm going to have this forever. Maybe that means that's it. I can't engage in my life. Um, and what you're talking about is exactly the way for people to see pain as one of the challenges, one of the things that are going on in their lives, but their lives can go on, and lives change and pain changes, and challenges change, and all sorts of things change, and pain is just one of those. I think how incredible for people to be able to get to that point, using the skills that you're talking about. Um, yeah. Um, another thought that I would love to hear your opinion on is what so many people say. Again, to your point of where is the pain located, and how do we understand it? Especially invisible pain, right? Sometimes if somebody's missing a leg and they say that they're in pain, people kind of get that. Um, but so much of chronic pain is invisible. You're looking at a person, you have no idea that they're experiencing chronic pain. And those people are the ones that will so often say, well, you know what, pain is all in my head, and I should just be able to get over it. I should be able to control it. I'm just weak. There is something, wrong with me for not being able to get a hold of it. What do you say to those people?
It's so horrible, the stigma that comes along with chronic pain. And I think a lot of people get the impression or are sometimes told, oh, it's all in your head, it's just emotional, or it's, you're just depressed, or yeah, you're not managing it effectively or whatever. And I think people do get the message, it's all in your head, or your pain isn't real, or you should be working harder. I think that's such a shame because nobody wants pain. No one is sitting around on purpose excited that they have chronic pain and can't engage in their normal daily activities. So it's not in your head, it's not your fault. Um, I do think there's a distinction between saying pain isn't exclusively in the body, it's rooted in the brain and it's all in your head. And I think it's very important for healthcare providers to make that distinction for their patients. And if we don't say it to them explicitly, they don't hear it. So I think it's really important for us to actually say that very explicitly, that it's not in your head, and I don't think you're making it up, and I don't think you're faking it, and I don't think you're weak, and this is not failing on your part. You're not choosing to be in pain all day, every day. It's really important, I think, to get that message across. But at the same time, I also, there's a lot of literature that shows that pain education actually changes a patient's experience of pain, and that learning about pain science changes your experience of pain. So I'm always thinking about, how do I deliver pain science to my patients in a way that's digestible and understandable and reduces the stigma that you're talking about? How do you, especially as a pain psychologist, right? Like, I am the last stop on the train. Nobody wants to see a pain psychologist for pain because it's a physical problem and it requires a physical solution. So when people get referred to me, they immediately think that their physician is saying, you have a mental illness. Your pain is in your head. And, usually that's not what they're saying. Hopefully that's not what they're saying. But the basic neuroscience of pain tells us that pain is produced by a number of different parts of the brain, right? Like your prefrontal cortex, which is attentional processes, and your cerebral cortex, which is like your thoughts and your beliefs, always impact the pain we feel, and your limbic system, which is your brain's emotion center. And I think that if our patients don't know that their pain is constructed by the emotion center in their brain, they'll never understand this link between mind and body, which we're always striving so hard to create. We're always trying to make this link for people. So the limbic system is critical in pain construction, and it's also critical in pain reduction. And I find that I often don't get buy-in unless people really understand that basic pain neuroscience tells us that thoughts and emotions can amplify your pain, and they can also reduce your pain. And without that critical piece of information, of course, patients are going to be like, well, why are you sending me to a pain psychologist? What is my emotional state, my stress during COVID, for example, or, my anxiety or my family dysfunction, or, what does any of that have to do with my leg, or my cancer pain or so I think, sort of putting it all together for people up front, for me, has been one of the most helpful techniques.
That makes so much sense. Kind of sounds like you're saying, yeah, pain is in your head to the extent that your brain is in your head, right? And it doesn't make it any less real, just because there is a lot of, neurobiological processes that are happening in your brain that contribute to pain. It's just as real, just as important. I guess the good news is that there is a lot we can do without the interventions of modern medicine, and make a really big difference through the kinds of improvements that you have a lot of control over yourself.
Exactly right. Yeah. And I would say the second piece of that is we have all sort of been brainwashed into believing that pain is a purely biomedical process, right? I mean, I think that gets taught across the board. Like we all believe that as like lay people or the public or patients. And also that's what gets taught in medical school, is this like biomedical model of health. And it couldn't be more inaccurate. And what's wild to me is that it has been known for many decades that pain is actually a biopsychosocial process by definition. And pain lives in the center of those three things: biology, psychology, and social or socioeconomic, functioning or whatever. It's right in the middle of all those three bubbles.
Mhm.
And we have this idea that if we target just the biomedical bubble, if we're just doing the medication and procedures route, that pain is going to magically disappear. But, sometimes that's true for acute pain, but what we know for chronic pain is that's never true. You have to target all parts of the biopsychosocial problem if you actually want to see a change in pain. And what we have a lot of the times in medicine is a focus on this biomedical bubble exclusively. We're missing the psychological components, the emotions, the thoughts, the memories, the coping behaviors, and we're missing the sociological or social bubble also. It's pretty wild. So I always educate patients on that too. Like, by the way, no one's ever explained pain to you. I'm just going to give you this crash course and actually like how pain works in your brain and in your body. And maybe that will change how you perceive your own pain and how you go about managing it or navigating it.
I bet that changing people's minds, about their pain, where it comes from, what it means, it makes a huge difference in their ability to cope with pain and live with pain.
Yeah.
So, in your book, you describe, so many really wonderful interventions to help people cope with pain and live their lives better. Do you have, I don't know, your top one or two or three, that are your go-to when working with people? What do you do?
Yeah. I love that question. I mean, my answer, you're going to appreciate this as a healthcare provider, is it depends, right? Like everyone who walks into my office comes with a different presentation, and they've always tried a variety of different things before they come to me. Everybody, like, everyone's been to like a huge medley of healthcare providers and specialists before they get to me. So I always want to know what they've already tried. I always want to know what resonates with them. I always want to know if they already have a multidisciplinary care team, because as a biopsychosocial practitioner, I believe that everyone requires an actual team. So, you probably already have like 7 physicians, but do you also have a PT and an OT? And have you ever tried biofeedback? And have you considered all these other pieces to the puzzle also? That said, yeah, like one of my favorite and you can tell obviously by how I'm talking about it, but one of my favorite interventions, and I do think about it as an intervention. I'm not saying it's a cure for pain, but I do think its intervention is pain education, just teaching people about how their brain and body works, because I think without that shift in perspective, you're not going to see a change in treatment or coping behavior or motivation. So I actually think that's like a critical key component of treatment, at least for me in my practice. Um, I happen to also really love strategies around pacing for pain. So behavioral change. So a lot of people with chronic pain are what we call in the avoidance cycle, which is so normal. It's like the fear avoidance cycle. Pain is an aversive experience. It triggers stress and anxiety and fear naturally and normally, evolutionarily. That's how we're built. And so, because of that, we fall into this cycle of avoiding activity, avoiding exercise, avoiding sometimes social interaction, avoiding even going outside. So, a lot of my patients are stuck inside, stuck on the couch, and haven't moved their bodies in a really long time. And of course, what we know is that inactivity and social isolation lead to incredible spikes in pain and a maintenance of the chronic pain cycle, where I'm in pain and I'm not moving and my body gets more stiff and then my pain gets higher and then I'm not moving even more. And we just like go around in this circle. So putting together a pacing plan for me is always really critical. And pacing for pain is much like pacing for a marathon, right? Like I wouldn't tell you to go outside and run 26 miles tomorrow. That would not work. You have to gradually work your way up to things. And that's even more so true when your body's been in pain for a long time. I always talk about it as a process of desensitizing a sensitive brain, which is what happens when we have chronic pain. The brain becomes more and more sensitive over time, especially the more we isolate and don't move. So, with pacing plans, we identify valued activities. They can be cognitive, they can be physical. I'm always gunning for at least a couple of physical activities. But it can be like walking, or it can be soccer, or it can be fudge making. I don't care, as long as it gets you off your couch. And then we put together the steps of the plan. Like, what can you do this week? How can we add on some more next week? So you're always gradually, adding a couple of minutes of activity. And then you move on to the next activity. So I think that's critical. And I'm also always folding in, I happen to really love biofeedback. It's one of my favorite interventions. And it was taught to me actually by our mutual friend and colleague, Eric Pepper, who I happen to adore. He trained me. I went to his office one day and I was like, I want to learn everything. And he said, I'm going to teach you to warm your hands to 90 degrees. And I was like, I'm a scientist and I do not believe in magic. And he hooked me up to his biofeedback machine and he used, relaxation and guided imagery and autogenic phrases. And all of a sudden, within like 2 sessions, I was warming my hands to 90 degrees and I felt so much power over my body in that moment. Like, wow, what else can my brain do to change my physiology? Which is all we want for our patients living with pain. We want them to believe in the power of their mind over their body, or to work, I should say, in concert. Um, so I always teach those strategies as well. But yeah, again, it really just depends on what's going on with the person when they walk in my door, but some medley of some combination of those things.
I love this. I mean, clearly you are creating a unique plan for each person. And, the gradual approach, I think, is so incredibly valuable because if somebody comes into your office and you tell them, all right, you're going to get back to your life and you're going to be running and jumping and, walking your dog and playing with your kids, and people go, that's not happening because in their minds, they have to get off the couch and go jump and play and, run a marathon, right off the bat. They don't see a way of doing it. But when they go through your gradual plan, by the time they get to running and playing, they already have so much other stuff under their belt that it actually seems possible and feasible. So you actually make that be possible for people, and give them a very clear plan to make that happen. And I know I love biofeedback, and Eric Pepper is also one of my mentors and teachers for biofeedback. One of my favorite practices I learned from him was warming your hands to melt a piece of chocolate.
Wonderful.
Yeah, so chocolate as your biofeedback device. You can use obviously all the super fancy thermometers and biofeedback equipment, or you can grab a Hershey's Kiss or piece of dark chocolate or something like that and make it melt, and magic, right?
Love that.
Um, so many things that are actually under our control when it appears to not be.
Exactly.
So. This is great. I'd love to hear about perhaps another client. The first client that you described. The kid who was able to live his normal life, kind of magically. And I'd love to hear another example, perhaps an adult. Since this newest workbook is intended for adults. I'd love to hear about somebody like that you've worked with and what happened.
Totally. I work with a lot of adults who have diffuse pain, and they're often told they have an amplified pain syndrome like fibromyalgia or some other chronic pain condition. Complex regional pain syndrome I see a lot also. I'm thinking of a woman in her 50s who had fibromyalgia and also chronic migraine, which I see a lot of. And I think actually chronic migraine is exploding during COVID. Of course, because we know migraine is in part triggered by stress and changes in blood pressure. And, COVID is nothing if not a major stressor for most people. And it's causing a lot of family stress and economic stress and money stress, pretty intense time of life. Um, yeah. So it was the same program. So, I mean, what I put together in the workbook is literally the program that I do with my clients. And you're right. I always am trying to create a unique and individualized program, but I always start with pain science. No matter who walks in my door, I'm always teaching the biopsychosocial model of pain, just so they know. I'm always helping them identify the different factors. So for her, what are the biomedical explanations for your pain? So genetic predisposition or tissue damage or sleep and exercise and nutrition. We also had her fill out what are the psychological contributors to her pain. That one's always much trickier for me because I have to talk about the stigma associated with that always and be careful to explain that we know that thoughts and cognitive factors affect your pain, and we know that negative emotions amplify pain, and we know that things like relaxation and joy and pleasurable activities reduce your pain. So I always have to do the science first, and we had her list those out also. She had a lot of family conflict and actually a long history of trauma as well. And just to say, I mean, what we know from the literature is that chronic pain and trauma are comorbid 50% of the time. So it's no shock at all. Like, that's one of the first things I recommend that people assess for in their chronic pain patients is any sort of history of trauma, especially with the ACEs studies. There's so many of them now, and we know the adverse childhood experiences, adverse early childhood experiences studies. We know that um, early childhood trauma leads to chronic pain and health conditions later in life. And there's just like so many studies now. So oftentimes I'll assess for trauma and patients will tell me about early childhood trauma, and I'll just hand them these studies that help them make sense of why their bodies are hurting so much. And then we had her fill out the sociological, the factors that she felt were contributing to her pain. And that led to a complete shift in her perspective of how she had been treating pain. She's in her 50s. She had been on, I don't even remember how many medications, but she had seen something like upwards of, I think, 30 something healthcare providers in the last few years alone. Um, and of course, had been on all the medications and had tapered off opioids, but had been on those too. So yeah, for her, it was putting together a pain program that was pacing. She really loved mindfulness. A lot of my clients do not. They're, again, sort of like me. I was like, why am I doing mindfulness for this physical problem? But she really loved it. She found it really calmed her pain system, made her feel much more able to take on the rest of her day and engage in those other activities, like the pacing activities we had put together for her. Um, and oh, for her also, we had a pleasurable activities scheduling system in place. So every week she had to pick a pleasurable activity to integrate into her life, because pain is such an aversive experience and it takes so much away from you that it requires a lot of effort and mindfulness to plan those back in or schedule those back in. She started volunteering at an animal shelter. She noticed that on the days she was with the animals getting fuzz therapy, which I believe in, her pain was significantly less. So yeah, she was a wonderful success story. So again, sort of to your question at the beginning, how do you coach your clients that they can live a life they love even if they have some pain? So she was able to notice that her pain would go up and down, and that there were all these contributing factors that would amplify pain volume and turn pain volume down. But she kind of came to that on her own. Like, I taught her the theory, and then she was able to fill in the different blanks of it. But yeah, she was able to notice that pain would go up and down. She had some control over pain volume. She was able to re-engage in pleasurable activities, you know, changed her relationships, changed her ability to work. Yeah. So, and I think that's a pretty typical story. Like, we can't always take away our patient's pain, but we can help them lower the pain volume, which is always what I'm thinking about. How do we lower the pain dial? and help them increase functional abilities and get back to their lives a little bit or a lot.
So powerful, right? And I think, so many chronic pain patients, that's going to be, good enough, right? Even though I'm sure lots of people would love to just have their pain be gone. But if you think about it, the idea of being able to engage in your life and do what's important to you and, live a life according to your values. I mean, that's what any of us want, right? Despite whatever challenges might come along the way. So.
Totally. And, if there were a magic cure for pain, a magic pill, a magic anything, you and I would be giving that to our patients. But what we know is that there isn't. Like the medications that are most commonly prescribed for chronic pain, like gabapentin has zero evidence of effectiveness for chronic pain. There's like all these articles on it now. And has like a variety of side effects. And opioids over time actually sensitize the brain to pain. We know that too. Opioids sensitize the brain. That means you're going to feel worse. The longer you're on opioids, the worse your pain is going to feel, not better. And I am in no way opposed to medication, particularly not for acute pain. I think it's brilliant and thank God we have it, right?
Absolutely.
But what we know from the research is that there is no magic pill for pain. So it requires this multidisciplinary biopsychosocial approach. What are the things that we can do to turn down pain volume in any given moment? You know, but there is no magic cure,
Well, I mean, what you're describing sounds about as close to magic as it gets, I guess. So, thank you so much for talking with me about this, and thank you for writing this wonderful book. I hope that a lot of people read it and benefit from it.
Yeah, I hope it's useful. And thank you so much for taking the time to read it and speak with me today.
Yeah, it's my pleasure.